Wow, those lights just came up. Hello, and welcome to the Provost Ethics Colloquium. It's great to see so many of you here on this lovely fall afternoon and beautiful weather outside, so I'm glad you guys could come inside for this. I'm Ellen Fisher, Assistant Vice President for Strategic Initiatives in the Office of the Vice President for Research. I'm also the university's Research Integrity Officer, or RIO. And as the RIO, I'm charged with fostering a research environment that promotes the safe and responsible conduct of research on our campus and in overseeing our process for managing allegations of misconduct, which often requires parsing the variance among ethicality, legality, and morality. Recently reported unethical behavior and irreproducibility in academic research has made big headlines and at a minimum reduces the public trust and confidence in our scientific community and in academia as a whole. Here at CSU, we pride ourselves in being committed to upholding the highest standards of safe and ethical conduct across all of our institutional missions, and we seek to empower our faculty, staff, and students to model ethical behavior in all of their endeavors. As evidence of this commitment, the Provost's Ethics Colloquium at CSU has promoted cross-disciplinary conversations and awareness about ethics-related issues, and has also encouraged all members of our community to engage in ethics seminars and other similar activities. The colloquium seeks to infuse ethics into and across the curriculum, while also sponsoring high-profile external visitors to help guide our conversations. Through these actions, the colloquium has fostered increased interaction and collaboration among members of our academic community to work with an ethical perspective on virtually all issues facing our community. The goal of the Ethics Colloquium series, which is what we're here for today, is to support, highlight, and enhance the activities that emphasize ethical issues in the professions and disciplines, particularly when such issues have larger social, civic, political, and economic implications, and to give the broader Northern Colorado community a transparent and accountable opportunity for dialogue on these topics, with all of us here at CSU as well. We're delighted to welcome this fall's external visitor, Professor Alexander Capron, who will be introduced by Professor Jahi McMath, Dean of CSU's College of Health and Human Sciences.
Thank you, Ellen, and I also want to welcome each of you here today. It's my pleasure to introduce, we have a distinguished speaker who will then be joined by a panel. So I'll go through the process of introducing each of those people right now. Alexander Capron is the Scott H. Vice Chair in Healthcare Law, Policy, and Ethics at the University of Southern California School of Law. He's also the co-director of the USC Pacific Center for Health Policy and Ethics, and a professor of law and medicine in the USC's Keck School of Medicine. In addition to fulfilling other national and international roles, Professor Capron served for 4 years as the Director of Ethics, Trade, Human Rights, and Health Law at the World Health Organization in Geneva. He has published 13 books, as well as dozens of chapters, articles in legal and other journals. Reports for the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research, and his work covers a broad range of topics in ethics in medicine, from stem cell research, genetics, and reproductive technologies, to pharmacological research in children, equitable access to medical technologies, and end-of-life care. And our panel members are Moti Gorin, who's an assistant professor of philosophy here at Colorado State University. He specializes in bioethics and moral and political philosophy. In addition to teaching and conducting research in the Department of Philosophy, Gorin works with the Research Integrity and Compliance Review Office of the Vice President for Research, where he helps to develop and implement research ethics and responsible conduct of research across the university. He's published articles in the American Philosophical Journal, or Quarterly, the Hastings Center's Report, the American Journal of Bioethics, spacing on this one, Philosophia. Did I get that close? Sorry. And Public Health Ethics. Before accepting his current position at CSU, he was a postdoctoral fellow in advanced biomedical ethics with the Department of Medical Ethics and Health Policy at the University of Pennsylvania. We have Bruno Sobral, the director of our One Health Institute and professor of microbiology here at CSU. The One Health Institute focuses on how to foster and support interdisciplinary research teams working on issues of the environment and health, foodscapes and health, urbanization and health, and using system thinking, community engagement, and a human-centered design thinking approach. Dr. Sobral recently served as the Chief Science Officer at Alcohol Biotech, a London-based feedstock research company that develops agricultural products for biofuels. Sobral was also the founding executive and scientific director for the Virginia Bioinformatics Institute of Virginia Tech, where he was a professor of plant pathology, physiology, and weed science. We also have Ms. Yvonne Myers, who is a proud CSU alum from the Department of Human Development and Family Studies and a tireless advocate for the promotion of healthy living for aging populations. Yvonne has worked with older adults in various settings across skilled nursing facilities, assisted living facilities, in-home care, and adult day programs. She has served as the Health Systems Director at Columbine Health Systems since 1998. She is also involved in numerous boards, associations to support older adults and their caregivers in the greater community. A couple of examples is she's immediate past chair of the Fort Collins Chamber of Commerce, board member of the MCR and PVH Foundations, and in addition, she serves on my Executive Leadership Council in the College of Health and Human Sciences and is an inaugural member of Women Investing in Strategies for Health. Bernard Rowland is a University Distinguished Professor, a Professor of Philosophy, a Professor of Biomedical Sciences, a Professor of Animal Sciences, and the University Bioethicist at Colorado State University. And I just mentioned to Bernie just a few minutes ago that he and Dr. Capron sounds like they have like 4 different bosses to go to, so nobody knows where they are. But Bernie is considered a leading originator of veterinary ethics. He's a major architect of the 1985 U.S. federal laws protecting lab animals. He's an author of more than 20 books, including A New Approach to Animal Ethics, Telos, and Common Sense. He co-edited the recently published book, The Welfare of Cattle. As a leading scholar in animal ethics and animal consciousness, he has been recognized with numerous awards, including the AVMA Humane Award and the Rocky Mountain Farmers Union Lifetime Achievement Award. In 2016, he was awarded the prestigious Lifetime Achievement Award from Public Responsibility in Medicine and in Research, the first time it's ever been bestowed on an animal ethicist. And the moderator of the panel this afternoon is Matt Hickey, who's a professor and University Distinguished Teaching Scholar in the Department of Health and Exercise Science, where Matt also directs our graduate program in Health and Exercise Science. He's the director of our Human Performance Clinical Research Lab and serves the university in a variety of capacities related to teaching and learning. So please first welcome Alexander Capron, and then following his remarks, the panel will be joining us. So thank you.
I don't know if the people in the booth are going to take it. Thank you very much. It's a pleasure to be here in this beautiful part of the country. On the way up here, I think I saw some of Bernie's friends out in the fields. I'm going to talk today about a span of time that is captured in these 2 photographs, one from 1968. On your left is Henry K. Beecher, a distinguished professor at Harvard Medical School, leading researcher in anesthesia, and as I will explain, the chair of an important committee. And on your right is a face you may recognize from the news in recent years, Jahi McMath, who died, perhaps for the second time, earlier this year. Just to begin, in the traditional fashion, I have no financial relationships or interests that are relevant to this presentation. I'm going to talk, as I said, about some things from a historical viewpoint to set the stage for our discussion. Talk about the problem, the medical insight that responded to that problem, the first medical consensus that sort of set things in place, how the law developed, and then end with 4 topics which may be of interest for the panel to discuss and for all of us to have a chance to address. The question of irreversibility or permanence in the situation of donation after circulatory determination of death. The question of diagnostic reliability in the field. The question of whether we are dealing with a legal standard applicable to all human beings in the country, or are we dealing with a matter of individual choice? And finally, the question, which I'm sure our philosophers will help us with, is this an intellectually, conceptually coherent idea? So the story begins in the 1960s with the development of circulatory support, cardiopulmonary resuscitation, and the creation of that now mainstay of hospitals, the intensive care unit. And what this created was a situation in which some patients who had suffered serious injuries, particularly those affecting their brains, were maintained and recovered, whereas others did not recover and could remain unconscious on the ventilator indefinitely. That is not forever, but for an indefinite period of time with no way of knowing when that was going to come to an end. And furthermore, in these patients, the existence of these interventions interfered with the traditional vital signs, which are heartbeat and respiration, because these were obviously artifacts of the interventions that they were undergoing. So this led to what was the central question in the late 1960s, which was, must treatment be continued in these patients as long as their bodies will respond? And the fact that the prevailing answer at the time was yes, was very hard on the caregivers, particularly the nurses who were caring for these patients, but also the physicians and residents, and on the families, and for many of the families also created a substantial financial burden because this hospital care was not either free or cheap. There was also a lot of concern, and this was a particular concern of Dr. Beecher's, and explains why he asked in 1967 for the dean to appoint a committee at the medical school at Harvard to look into this question. And it was really the question of whether or not resources would be permanently tied up to the point where patients who were coming into the hospital whose life could be restored couldn't be treated. Also on people's minds was a notion which it would surprise a lot of people today, but there was an active concern, for good reason, based on the statements of some prosecutors, that the withdrawal of treatment from a patient on a ventilator, so-called pulling the plug, could lead to a criminal homicide prosecution. Now, the medical insight that began to change this picture came in 1959 when several French physicians published their findings on what they called coma dépassé, or beyond, patients in a state beyond coma. These were mechanically ventilated patients whom they maintained until that became impossible, and then they undertook autopsies. And the brains of these patients were necrotic. That is to say, the brains had ceased functioning, and the cellular degeneration had occurred long before the point at which their bodies were no longer able to be maintained through the ventilators. And other people studying this reported that in these patients there was no blood flow to the brain on angiography. And during this period, after this discovery and the announcement, some physicians, including a fellow named Guy Alexandre in Belgium, began, in certain cases where there had been severe cranial injuries, using these patients with the permission of their families as kidney donors. In other words, taking the kidneys from them while the circulation continued from the respirators, but they were being treated as dead. Now, some leaders in transplantation were skeptical of this, and the first person I'm going to point to is someone well known here in Colorado, Tom Starzl. And at a symposium on these issues in 1966, he expressed the view that he and his team could not accept such patients as being dead as long as heartbeat remained. And Sir Roy Calne, another pioneer in the field, said that a patient with heartbeat cannot be regarded as a cadaver. So at the time, there was this tension, and that's the area into which the Harvard Ad Hoc Committee to examine the definition of brain death published its article on a definition of irreversible coma in August of 1968. This is a committee of 10 physicians chaired by Henry Beecher, with one historian of science, one theologian, and one lawyer, all members of the Harvard faculty. Now, Beecher's objective, besides dealing with this question of patients whom he thought were tying up resources in a useless fashion, also wanted to take this initiative in order for the medical profession to retain control. And he was a believer that there really didn't need to be much of any law involved. And indeed, the lawyer on the committee wrote up about a third of that article in JAMA in 1968, and it basically explained why legislation wasn't necessary and that physicians could simply adopt new practices. The report was very influential due to the prominence of the members of the committee and the prestige of their institution, and speaking particularly of how to deal with residents who were new to the field and might be somewhat disconcerted at the notion of turning off these machines, or by the time the committee's report came out, although not when it began its work, by the time it came out with heart transplantation having occurred for the first time successfully in December of 1967, the question of these patients then becoming organ donors. And he sort of said you had to calm down these residents and assure them that this was all legitimate and this was all right, even though they looked as though they were removing organs from living people. Now, Beecher's committee in some ways got us off slightly on the wrong foot, and in that title page, if I went back to it, you would see that this is a report on irreversible coma by a committee on brain death, and in the course of their article, they talked about the permanently non-functioning brain. And I think ordinary language looking at these terms would say, you're not talking about the same thing there. For one thing, the very phrase, which is now embedded in our discussions, and I find myself using it just because talking about death determined on neurological criteria is such a cumbersome way of speaking of this, but the phrase brain death is so confusing. to physicians and certainly to the average person, when we talk about death, if we talked about the death of a dog or death of a human or something, we're clearly talking about an organism that dies. And yet the phrase brain death might suggest either of one of two things. A, that there's a special category of death called brain death, or that we're talking about a dead brain. But organs don't die. Organs cease functioning. It's organisms that die. And so Beecher got us off a little bit on the wrong foot. Now, some people refer to the 3-2-1 aspect of the report, and I go through this quickly because there's a persistence of these basic elements of the determination of death today, although there have been many refinements. So the three-part are the three basic clinical characteristics that the committee described. First, that there would be unreceptivity and unresponsivity to painful stimuli and inner need. Second, that there were no muscular movements or spontaneous breathing, and no elicitable reflexes. And of course, they had to later explain that they excluded from that any spinal reflexes. Then there were two preconditions. First, that hypothermia be excluded, so the body had to be normothermic. And secondly, that there were no CNS depressants on board, which could suppress the patient's response to the test to see if they were responsive. And all sorts of tests were used for that. And finally, there was a confirmatory test, which was an isoelectric EEG. Now, although Beecher had said law wasn't necessary, very rapidly some physicians said, well, we're not going to be able to follow these guidelines from the Harvard Committee unless we have the assurance that what we're doing is legal. And so a physician member of the Kansas legislature introduced a statute, which was a rather clumsy statute, unfortunately, but that was adopted, and then several other states copied that statute. And then at that time, that whole approach got a lot of criticism. And Leon Cass and I wrote a statute to try to address the subject in a more, a way that took better account of that criticism. By 1979, basically a decade after the committee, there was a patchwork of different laws, state laws, and this presidential commission that was mentioned a moment ago was given a whole bunch of charges, and one of our mandated reports was on the matter of determining death. And the first thing we saw was that in addition to the Capron-Cass statute, there were statutes proposed by the American Bar Association, the American Medical Association, and the National Conference of Commissioners on State Laws, which had made a Uniform Brain Death Act. And so what the commission did was to get these groups together and try to come up with a single act, because in many states, legislatures were ready to act in this area, but then the people who related to the state medical association would be told, well, this is the bill. And the Bar Association would tell them, this is the bill. And their members of the Uniform Commissioners Group would say, no, this is the bill. And maybe I wasn't running around the country telling them this is the bill, the Capron-Cass statute, but it was out there. And so then they thought, oh, well, are we about to step into a minefield if we go with one of these statutes? They look alike, but are they different in some way that we can't understand? So that kept a lot of the states from acting. The commission set forth three general principles to guide the work. First, there was no interest in doing a sort of a theological or purely philosophical analysis of saying, what is the definition of life or what is the definition of death? What was necessary was setting a way for there to be basic physiological standards. There was deference to medicine, but a recognition that this is not a matter just for experts, it's a public policy matter. And that it wasn't wise just to leave this to the courts. And there were a number of decisions during this time when, for example, victims of homicides had been taken to a hospital when they weren't quite dead, and attempts were made to save them, and then they died and they became organ donors, and the defendants, the criminal defendants in those actions, raised the objection that they hadn't killed the patient, the doctors had killed the patient, because the patient still had respiration and circulation, and that was the state law at the time. And so it became obvious that waiting for courts to decide if they wanted to update the common law view on what is life and death wasn't going to work. So in 1991, the commission issued its report on defining death, and the statute, the Uniform Determination of Death Act, was also approved by those other three groups in place of their previously existing statutes. The act had four formal features. First, it had to apply uniformly to all persons. It didn't apply to organ donors only. It didn't apply to victims of assaults. It didn't apply to men or to women or any other group. It applied to everyone. And it applied for all legal purposes. Importantly, remembering as you do when this began, the big concern was, can we stop treatment on people? It described who was dead. It didn't say what should happen after that. Now, most brain-based determinations of death in ICUs are actually made on patients who are not prospective organ donors. So it isn't a statute narrowly for organ donors. And the question of, is the patient dead, is one way of answering, should we continue treatment? Because if the patient is dead, the answer is pretty quickly going to be no. It may be that we're going to continue to intervene with this dead body to maintain the organs for a brief period of time, but that's no longer treatment for that patient. But it's not the only or the principal way, and by this time, it had become accepted by the courts that, in fact, pulling the plug on a patient, when done by proper procedures and with oversight, was not an instance of homicide, and doctors did not need to fear that they would be prosecuted. The fourth feature is that the statute should provide standards, but not write into the law the medical tests or procedures through which those would be implemented. And you can think, if you would, of what happened when the Supreme Court, in the abortion context of Roe versus Wade, put medical information into their first formulation of when women's choice about abortion was protected and when the state instead could restrict that. And with time, with the changing of the ability to maintain fetuses outside the uterus, that trimester format became outdated. And we were saying there, not by reference, we didn't reference it, but you can see perhaps the advantage of keeping that information out of the statute. So this is the language of the statute. An individual who has suffered either irreversible cessation of circulatory and respiratory functions, or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. So I want to just highlight those ideas, the either aspect, the entire brain aspect, and the medical standards. So those first two features are the idea of inclusiveness. Now, there were a number of people, and for example, that Uniform Brain Death Act, that took the approach that the brain is the master organ, and what you need to do is say, is or is not the brain still functioning? And that's what concerns everyone. And our view was, you'll create confusion if you do that, because most deaths will continue to be determined on circulatory and respiratory grounds. The ordinary common death, not in an intensive care unit, not even in a hospital, will be judged on that basis. And doctors, in doing that, are not going to stand there and say, well, person's not breathing, they haven't had respiration, they're cold, the body is cold, so I think they've lost their brain function, so I'm going to say they're dead for absence of brain function. No, they're going to say no circulation, no respiration, the person has died. And we thought it was important to state that explicitly, but the Kansas statute had one section on the determination by circulation and respiration, and another section entirely on the brain functions, and hadn't explained that they were alternatives to each other or why they were both there. And that gives the impression that we have two kinds of death. The idea here is this is a single kind of death. It's a place that you can look in either of two windows and see what's going on, but it's only one phenomenon. Also, having both and including the circulatory and respiratory makes clear that this is an incremental process. We are adding on for those situations in which we cannot tell whether or not there is circulation and respiration, or whether they have ceased and have been replaced mechanically. So it's incremental. And the second feature is this notion of the whole brain. And again, there were those who argued, no, what's really important to human beings, what makes us human, is our ability to think and to interact. And once that's gone, you're dead. And there are any number of jokes about people who have not lost that ability permanently, but are teenagers and have lost it functionally, and saying, oh, they're just brain dead. They're watching so much TV, they're glued to their screen or whatever. And that colloquial idea of brain death had its equivalent here, but we said, no, we're talking about all those functions, and you would certainly never say that a person who had brain stem functions and still had spontaneous respiration was dead. Now, the idea of treating it that way was therefore rejected both on principled grounds and on practical grounds. I mean, if you had a person who had permanently lost all consciousness but was spontaneously breathing, these patients are sometimes described as being in a persistent vegetative state. The idea that they were dead and ready to be buried is falsified by the fact that they're spontaneously breathing, and you would have to take active steps to make that stop. And that seemed to be the sort of thing that people would say, this person is not, just in common sense terms, is not dead. But there was another reason, and that was, it was not widely understood or agreed upon among neurologists and so forth at that time about what is the measurement of the absence, the permanent absence of higher brain functions, or which particular brain activities would qualify as an absence of higher brain functioning, unlike a measurement of the whole brain. And so the UDDA encompasses the higher brain loss patients because it encompasses all. So they are included in the definition, but merely having higher brain loss is not enough. The other thing from the statute is this accepted medical standards. And one of the ways of making sure that such a document existed more up to date than the Harvard report was that we convened all the leading experts on determination of death. We identified through literature searches and so forth, 56 of them, they all agreed to participate. And they came up with a set of guidelines for the determination of death. They state their aim is to eliminate type 1 errors and minimize type 2 errors, that is to say, Type 1 errors would be calling dead someone who is not dead. Type 2 errors would be calling someone not dead who is dead. That the standards can be applied without unreasonable delay, so that they should be the kinds of things that most hospitals would be able to easily administer, that they be externally verifiable, and there was a large body of literature on all the ones that were used. This document was submitted for information to the commission and was published in a medical journal, but it did not go to the commission for approval because the commission was not passing on the medical criteria and tests. And the law does not prevent those medical criteria and tests from being improved of light of new findings. And that has indeed happened. And there have been several groups, the American Academy of Neurology and so forth, and the pediatric groups that have published such standards. So let me turn in conclusion to the 4 challenges. Back in the period between the 60s and the 80s, all the focus was on brain-based determinations. But the statute, as I've just said, recognized circulatory respiratory determinations out of the recognition that they were going to continue to be the major way of making these determinations. And our medical consultants had talked about a loss of functions and irreversibility being established in these patients, just as they talked about loss and irreversibility in brain-based determinations. But they treated it quite briefly because it seemed very straightforward. And an example of a more complicated case would probably be if CPR has been attempted and resuscitation has not worked and the body has not started breathing again and had a heartbeat. At the end of that, death is declared. So in more recent times, the question has arisen, what about removal of life support that won't be restored? That is, they say it's going to be removed but not started up again at the request of the patient or the family. And this is a very common situation now where people reach the conclusion that a treatment is not being beneficial to the patient. And in some of these patients, it would be possible if you overrode the promise that you had made to the patient to actually be able to get the heart and lung to work at least briefly after the withdrawal. So if they aren't going to be reused, the withdrawal will be permanent. But if they were reused, it might not be irreversible. Now, if you wait a period of time, at least 75 seconds, there are no recorded instances of spontaneous restoration of breathing and heartbeat, except in cases after CPR. In some patients, the CPR procedure itself, the patient is trying to breathe again. It doesn't start right up, but starts up a little later. But in patients who are simply in a hospital, treatment is withdrawn, there's no recorded instance of spontaneous restoration after 75 seconds of asystole. So the heart stops, there's no breathing, no heartbeat, 75 seconds, no case. In some young patients, however, the whole picture of the loss of these functions is different, and particularly the victims of drowning or particularly drowning in very cold water. There seems to be some kind of a diving reflex that manages to preserve all of the oxygenated blood is in the brain, and the tissues just are not destroyed as fast. And this is a chart modified by one that my friend Frank Delmonico created. And I just want to show this would be the course for a brain-dead patient where after the determination of death, the ventilator is discontinued and either goes to organ recovery and transplantation or the body would go to the morgue. Where some brain functions remain, this is after a devastating brain injury, if there's a prognostic decision by the family and the physician that consciousness cannot be restored and further treatment is not beneficial, a decision can be made that the ventilator will be discontinued. And if this is a person who has agreed to become an organ donor, then you wait for asystole and respiration. There are different standards here, but 5 minutes is the most common waiting period. There's no spontaneous resumption of heartbeat. At that point, there's a decision that brain function has been irreversibly lost because of the absence of brain circulation. This is still an issue. Some people say, for the reasons that I just mentioned, that there might be in some of these patients restoration. And there's a difference between Europe, where out-of-hospital patients are sometimes used in this circumstance, and they have undergone active CPR, and then they're sent to the hospital in an ambulance where they're continuing to get intervention, versus in a hospital where there's been no attempt to resuscitate. If this model, the so-called donation after circulatory determination of death, occurs, there would be either no resumption of circulation, and then after the organ is recovered, ex situ circulation by hooking the organ up to a heart-lung machine, or no ex situ, and then transplantation, or alternatively using ECMO to restore circulation. But if that happens, and this is particularly done in Europe, then you need to prevent the blood from mostly going up to the heart and the brain. You want to keep it in the abdominal organs, and so a balloon aorta, a balloon is put into the aorta, inflated to block the circulation. That does give the appearance to some people that what you're trying to do is keep blood from getting to the brain, out of fear that if it got to the brain might revive. The second challenge is one of individual choice. There are religious groups that have been accommodated in the laws in several states as to brain death. Originally, when this was done, it was thought this was going to be a quick matter. It's a matter of letting the family wait and watch, and then the body will soon, the heartbeat and respiration will become impossible, and you can have a heart and lung-based determination. But the question then arose, can this also be a matter not of religious belief, but just of individual belief? And it obviously sets up this question, is there this uniform idea of who's alive and dead, or if I have certain religious beliefs, am I alive while anybody without those beliefs is dead? That intersects, obviously, with the Jahi McMath case. Let me just remind you, back in 2013, she was a 13-year-old girl at Oakland Children's Hospital. She had a complex tonsillectomy. There was massive hemorrhaging. There was some indication of lack of adequate medical attention as that began. Her family was therefore very upset, and they were very suspicious of the physicians. They refused to accept the diagnosis of brain death, and they then sued to have the withdrawal of treatment prevented, and later they also brought a malpractice suit. Based on reports of several consultants, the judge was satisfied that Jahi was dead, but agreed to a settlement that was reached between the parties, which allowed a death declaration, but also transfer of the body to the mother so that she could transport it, and she arranged for a medical plane to fly to New Jersey, where, as we just saw, patients who might be dead in another state can still be called alive. And Jahi was sustained with the respirator, medication, and a feeding tube for 4.5 years in an apartment. And all of that treatment was finally ceased on June 22nd of this year because of massive bleeding due to her kidney and liver, and a New Jersey death certificate that was then issued 4.5 years after her California death certificate. So is this a matter then of the issue of individual choice? There was no real religious belief. They were not Orthodox Jews. There was no prior belief, but she was able to assert. Is it a question of diagnostic error? Now, that can be very upsetting when you think about it, but we all know that there are errors in medicine, and that doesn't disqualify the whole practice of medicine. Or was it because of an undetectable or simply undetected blood flow to the brain, or the failure of the test to actually detect the persistence of some of these brain functions? Her mother circulated to various doctors films that she made of Jahi in which she seemed to be responding with a twitch of her finger or something to commands. Other people looking at it said, we don't know how many of these pictures, how often did she ask for it and nothing happened. But some experts looked at it and said, that looks to me like a reflex. And basically, her case raises this issue if indeed her brain was destroyed, and I don't know if we will ever know that from an autopsy or whatever, but if the brain was destroyed and yet she lived in terms of responding to the respirator and the drugs and so forth, going into menarche and so forth, and having other signs of hormonal development, was she dead as we would understand that? And the final question grows out of that. Is there a bright line or a spectrum? Was she simply down at the low end of the spectrum, but we think she was on the far side of the line, but she turns out not to have been because our tests aren't quite good enough? And as for the question of line drawing, which functions are decisive? Why have we picked these particular functions? Or is the determination of death really prognostic rather than diagnostic? Obviously, the determination usually becomes self-fulfilling, and then a few cases come along, like the McMath case, where it isn't self-fulfilling. She has a determination of death, and yet these bodily functions persist, and they have persisted in others who have been maintained, the random case here and there, for many years, and even in one case for 20 years. And finally, medicine may need to refine the criteria for what must be lost and how irreversibility is established. But then the question is, does the law need to change, or would those changes simply be refinements within the terms of the law? So these are the questions some of the questions I hope we get to talk about. Thank you.
Panelists are reading my mind. I'm going to ask you to join us all up here. So we're going to have formal responses from our four panelists. I'm going to ask our philosophy friends to start us off. And Bernie, I'm going to ask you to go first if you would. You're welcome to be seated while you respond, or you can come to the podium. We have 3 wireless mics over here. And so, Bernie, you've got the floor, and you're welcome to sit or stand as you prefer, my friend. Dr. Rowland is graciously giving the floor to Moti to start us off. Thank you both.
Well, hi, everyone. Can you hear me? Thanks for being here. I want to thank the Provost for supporting this series. I want to thank Matt Hickey and Gwen Gorzelski for all their work organizing this event. So I'm not going to talk for too long. I think we'll hopefully have a nice discussion. I want to make a few remarks. I'm going to start by revisiting a position advanced by the philosopher Peter Singer in his 1995 presidential address to the International Society of Bioethics. In his lecture there in 1995, Singer argued that the traditional sanctity of life ethic was collapsing. And by the traditional sanctity of life ethic, Singer meant the view that all human life, irrespective of its quality, was valuable. And this is a belief that he thinks least in Western society, we were committed to for thousands of years. And then he thinks that sort of broke somewhere in the middle of the 20th century. So he pointed to some landmark legal cases in both the US and the UK that served as evidence for his thesis that we no longer accept the sanctity of life thesis. Some of those cases granted patients or their surrogates the right to refuse medical care, even when doing so meant the patient would die, while other cases, and here he was referring in particular to the British case of Anthony Bland, a 17-year-old permanently unconscious patient. That case granted the right of physicians to withdraw life-sustaining care without the consent of the patient, simply because, in the judgment of the House of Lords, the patient's life was no longer any benefit to him, and the question of whether he lived or died was, quote, a matter of complete indifference to the patient. So Singer welcomed all these judgments, and the last one in particular, because Singer believes that anything, including a human being, that permanently lacks consciousness has no interests. And having no interests excludes one from the moral community. So once something has been excluded from the moral community, it becomes permissible to use that being in ways that benefit others who do have interests, such as patients. In this case, we're concerned primarily with patients who are in dire need of life-saving organs. So for Singer, the question of how to define death is less important than the question of how to ascertain when the higher functions of the brain are no longer operating. He doesn't really care whether we call these people dead or not, right? Singer's not the only person to take this view, and I think ultimately it's the right view to take. But that being said, there are some complications, one of which is the dead donor rule. The dead donor rule insists that a person can donate an organ only if she's dead. It's sort of motivated. The dead donor rule, right, this is the rule that insists that the person can donate an organ only if she's dead. This has put pressure on the medical and legal community to advance a conception of death according to which a person is dead when their entire brain has irreversibly stopped working. So that's what we saw with the ad hoc committee in 1968. This has allowed the procurement of viable life-saving organs from people with beating hearts and other ordinary signs of life. But it has also meant that the legal definition of death has come apart from the biological definition and probably from our common sense definition as well, right? We're talking about warm bodies, beating hearts, in some cases people who are growing. Kind of hard to accept the fact that they're dead, but indeed they are dead legally in some cases. So I think there are at least two ways, there are many more than two, but at least two ways that we can respond to this tension. The first is to do away with the dead donor rule and to allow physicians to remove organs from people who are still legally alive, at least when the patient or their surrogates have consented. This could and almost certainly would raise difficult questions regarding the criminal law. For example, whether the removal of vital organs from a legally living person would constitute murder. Okay. The second route, which I offer really quite tentatively, and I was happy to see this is one of the questions that Professor Capron lists. So the second route, which I offer, I'm not sure about it, is to preserve the dead donor rule and to adopt a disjunctive account of legal death, one that leaves room for cultural, religious, and philosophical differences. Already, the state of New Jersey, as we just saw, allows for two conceptions of death, one of which is based on the Jewish religious belief that a person is not dead until her heart has stopped beating. In New Jersey, two brain-dead patients in exactly the same physiological states can differ with respect to their status as living persons, with one of them being legally alive, the other being legally dead. As far as I know, this hasn't caused any significant problems, despite the fact that it appears quite odd to many people when they first learn about it. So the disjunctive account, so this is disjunctive, by disjunctive I mean you're dead if this, or this, or this, or this, right? You could have a bunch of disjuncts. The disjunctive account would say that a person is dead if any one of a set of conditions are met, with the choice of which condition left to the patient or the surrogate, or perhaps in some cases the medical team or a court, so that remains to be clarified. One condition might be the irreversible cessation of all brain activity. Another might be the irreversible cessation of circulatory and respiratory functions. Yet another might be the irreversible cessation of the higher functions of the brain or of consciousness. So that's the one I would choose for myself, right? If I'm permanently unconscious, I don't care what you do to me. Right? I prefer that you could help other people, but I don't really care. We can imagine other conditions, too, coming from various religious or cultural traditions. We would, of course, have to be very careful about which conditions we admit, and there are difficult practical questions about how such a disjunctive account would interact with the criminal law. But such problems should not be too contentious, so long as people do not feel as if some alien conception of death is being forced on them or their loved ones. So I think this is where Jahi McMath's family has a real claim of complaint here. They simply refuse the diagnosis of death. But right, generally speaking, we don't care too much about what might count as death for other people. We're going to care a whole lot when it comes to us or our loved ones. So long as we can sort of pick the conception of death that suits our philosophical or religious beliefs, I think most people wouldn't care too much about how those definitions did or didn't apply to others. That's an empirical claim. I don't know if it's true, but that's what I suspect is true. So we don't force conceptions of death on other people. And what counts as legal death will be a legal fiction in any case. Right? The legal definition is not the biological definition, and it will never be, so long as we want to obtain organs from people. So what counts as legal death will be a legal fiction in any case, as we've already stepped away from the biological definition. So why not make room for a definition that is sensitive to the pluralistic nature of our society? Thank you.
I do want to remind my panelists we've got 3 live wireless mics sitting right in front of us, and now might be a good time to grab those and make those available. But Bernie, again, I think maybe you're next in line in terms of formal remarks, if you'd like.
I want to begin by expressing my appreciation for the opportunity to share a podium with Dr. Capron, whose work I've known since the 70s and admired. And he's really carved out a niche that has been of seminal importance in society. I'm going to take a little deviant tack because my ethics work is in the area of animals. So I want to talk a little about animal death. No one with any sense of cultural change can fail to notice the elevated status of companion animals in our society. Indeed, the very use of the term companion animal as opposed to pet eloquently bespeaks the way in which that augmented status has entered into political correctness. Illustrative of this change is an event that occurred when I was a teenager living in Brooklyn, New York. I was standing outside my house more than 50 years ago when suddenly one of my neighbors, a woman in her mid-50s, began running down the middle of our quiet street wearing a bathrobe and weeping hysterically while holding the body of her dead chihuahua. She was screaming repetitively, "First my mother and now you." Her unashamed and very public display quickly drew a crowd. The dominant response was, "For Christ's sake, Mary, it's just a dog. You can get another one." Manifestly, the expression of that sentiment was of no consolation to her. In fact, the lack of empathy and understanding evidence simply brought forth a new bout of tears. No person today possessed of even minimal sensitivity would respond the way the neighbors did. According to repeated surveys, a minimum of 89% of dog owners, up to a maximum of 99%, profess to view their animal companions as, quote, members of the family. Whereas once dogs, for example, with hind-end weakness would have been euthanized, today one can purchase carts that essentially replace the hind limb and allow mobility for the animal. Many people with geriatric animals will not go on vacation if it means leaving the animal in a kennel. Doggy daycare, so-called, is a growth industry, as are luxurious and expensive boarding kennels. More than 20 years ago, the New Yorker reflected the new status of dogs in a cartoon showing a wedding reception line with the dog shaking hands with all the guests. One guest is saying to another something like, "I know it's odd, but they say he's a member of the family." A striking example of the new status of companion animals, particularly dogs, traces back to the early 80s with the creation of the Animal Cancer Center at Colorado State University. At that time, a front-page story in the Wall Street Journal reported that there were clients at the cancer center spending more than 6 figures, and that's 1981 money, on treating their animals' cancer, including one business CEO who camped in the veterinary hospital parking lot in his RV for 6 weeks, the duration of the cancer treatment. The proliferation of specialty practices in veterinary medicine eloquently attests to the same point. One can conjecture with some plausibility why this societal change in attitude has occurred. First of all, we are socially isolated from one another, particularly in urban and suburban locales. Gesellschaft, i.e. disconnected aggregates of individuals, has ever increasingly replaced Gemeinschaft, i.e. tightly bonded organic social unity. Divorce affects about half of all marriages, leading to a feeling that home is no longer a stable source of comfort and belonging, particularly among children. I often ask students in my introductory courses how many of them come from, quote, broken homes, end quote. The rate mirrors closely the societal situation. I used to ask those kids if it hurts, but I quit doing that when so many of them would start to cry. It was very sad. For much of the history of the 20th century veterinary medicine, little could be done for seriously ill animals suffering from chronic diseases such as cancer. Although treatment modalities now exist, they're extremely expensive and very few people carry pet health insurance. As I mentioned a few minutes ago, we're talking in the early 80s about 6 figures. The situation creates horrible moral tension for companion animal owners and for veterinarians. In many cases, the only viable choice a veterinarian can offer is euthanasia to relieve suffering. This is a very difficult decision for all humans involved. The client cannot save a beloved friend, the veterinarian cannot treat the animal for reasons of costs, not realize what he or she is trained to do, even if there is a treatment modality available. This intolerable situation creates significant moral distress among veterinarians and almost certainly plays a major role in the suicide rate among young veterinarians. In Great Britain, that's the highest of any profession at all. In addition, animal owners will be afflicted with lifelong guilt. A little bit over 20 years ago, I wrote a paper on euthanasia and moral stress. That's become kind of a touchstone for people who think about these things. In addition, even if affordability of the treatment is not an issue, there is always the perennial question of when one gives up treatment. And I can attest to the fact that inevitably what is left is the persistent, nagging question of whether one acted too quickly in euthanizing the animal, or conversely, whether one waited too long. The irony here is that animals seem to be incapable of fearing death per se. Heidegger defines death as, quote, the possibility of the impossibility of your being, a notion that animals are incapable of grasping in the absence of linguistic abilities transcending the momentary. Animals thus live far more in the moment than humans do. A human's current life world balances the past and the future. The possibility of death, as embodied in disease, affects long-term projects, such as wanting to finish one's book, wishing to see one's children graduate, hoping to see Ireland again, etc. Lacking those mentational tools, death to an animal is far less tragic than it is to a human. A peaceful, painless, stressless euthanasia is therefore far less tragic to an animal than it is to a human, particularly if the animal has lived a pleasant life. Nonetheless, not being able to treat one's best friend for financial reasons, leaves a black mark on one's soul. As a society, it is incumbent upon us to take cognizance of this emerging moral dilemma. Thank you very much.
Thank you, Bernie. Yvonne, can I ask you to contribute next to our discussion, and Bruno to follow?
So good afternoon. I want to also echo the great privilege of having the opportunity to participate And also a big thanks and shout out to the provost and the team that has decided to put together these types of conversations where ethics and morals are front and center to scientific research, medicine, and other areas. Not being an expert either in philosophy, I mean, I have a PhD, but I wonder how many non-philosophers' PhD really philosophize. And then also not being a physician or a veterinarian, I must come at this from a very humanistic perspective. And in that regard, one of the things I wanted to bring up is this notion of consciousness. So I think there's quite a bit of thinking around consciousness being an emergent property of the brain. Possibly that is a somewhat consensual viewpoint within the sciences. But there are other viewpoints, and I would say that in my own readings around consciousness and consciousness research, I think science is ill-equipped at present, at best, and sometimes simply refuses to engage in the conversation of what is meant by consciousness, where does it come from, and what is our relationship with it. So while personally I feel like consciousness, the departure of consciousness from the body, would be a really, at least to me, meaningful definition of death, the fact is we don't understand consciousness. And the other viewpoint that I've been very curious about is whether the brain is just the sensing organ for consciousness, and consciousness exists beyond the brain. I'm not going to take a position on either of those, but those are at least two viewpoints that are dualistic. The second point I want to make is I identify as a multicultural person. I was born in Brazil. I've spent most of my life now in the United States. I've lived in French-speaking Switzerland. My sister is married to a Mexican-American. My wife is from Central America. And my oldest daughter, a couple of years ago, got married to an African-American from a family in Los Angeles. And as I experienced these different cultures and perspectives, one of the things I notice is, and I really want to validate the point that was made earlier, there are different perceptions about not only death, aging, dying, the value of the elders. And I don't see how we can not honor those in some way. Now, again, I'm not a legal expert. I'm not saying these things are easy. But I do think that, for example, how many of you know what today is outside of just being November 2nd? Anybody? Can somebody shout out what today is? Dia de los Muertos. And Dia de los Muertos comes from an Aztec tradition that, like many traditions, the European settlers, mostly egged on by the church of the time, felt that, okay, this is paganism, we shouldn't do this. But it kept seeping through the cracks of colonial oppression. And in the Aztec tradition, I'm not from that tradition, but what I have read is that it would be disrespectful to mourn a dead person. So it's a party. Actually, yesterday, we welcomed back the children who passed away early. And today, we welcome the other folks. And it is a party. And if none of you have ever experienced it, it might be worthwhile to experience it. It is a celebration of their lives. They make a long journey back to the living. And there is a celebration. And it is really very different in my experience, having experienced multiple different versions of what people do when people dear pass away. It really is a very different experience than when I go, for example, to the passing of somebody in more, let's say, the Anglo tradition. And so I do feel like I want to end in the same words, which is, it seems to me like the humanistic thing to do is to create a system where traditions can be honored. Thank you.
Well, I appreciate going last because I don't think I'm the smartest one in the room, so it's been great to listen to all of their perspectives. I'm coming at this from a person who, oh my goodness, who started as a student here and took death and dying. And it was a pretty shocking class to be 20 years old and be in death and dying and to tour a funeral home and have the funeral home director say, have a big jar of cremains and say, if the temperature isn't hot enough, we'll still see your teeth and your rings. And it was pretty Shocking experience. During the time of my death and dying class, who is now my husband, his dog became ill. And as it turned out, he did not have an enzyme to digest food. We were college students. We could afford, for a few months, $50 a month of VioCase to replace that enzyme so he could eat. But we could no longer continue doing that. And so I needed to take that dog to be euthanized. And I felt it was somehow symbolic during my death and dying class to understand all of that. I graduate from CSU in a degree, Human Development and Family Studies with older adults because I love my grandmother and my crazy piano teacher, who to this day, I don't know whether she's demented, had a personality disorder, or just had a mental illness, and it didn't matter. I took piano lessons all the way through high school and thought she was amazing. And my first job was at a nursing home because I met my husband at the drugstore and I wanted to stay in Fort Collins. And that was 35 years ago that I worked in long-term care. When I started in long-term care in 1982, we did not have living wills. There were only financial powers of attorney. There was nothing. And when a person who was older went to the hospital, everything was done for them. And families would say, I'm not sure that's what I want. Or the patient would come back and say, I'm not sure this is all that I wanted. And so we developed the living will. And everyone thought that was the answer. The living will was going to help people to make decisions. Well, guess what? It only addressed tube feedings. That was it. And very few people chose to have a tube feeding in their older adult life. So the living will really served not much purpose. Then we developed the medical power of attorney, which put a lot of pressure on families, neighbors, nephews, nieces, to be the decision maker. And I was social worker at Columbine West, and I would do the admission paperwork. And on that admission paperwork, it'd say, who is your funeral home preference? And I will tell you, I had one. It was the niece and her husband, and her aunt was 92 years old. And they said, we don't know. We've never discussed it. Like, what the hell? She's 92 years old. It didn't come up once. And not making that decision. The physician was in the building at the time. I said to the doctor, did our patient at ever time discuss with you what she wanted for the end of her life? The funeral home and also code status. Did she want her heart resuscitated or not? And he looked at the family and he said, if we do CPR on her, we will puncture lungs by breaking her ribs. We will puncture her lungs. She'll die anyway. You don't want that to do that. And those were kind of the conversations of the time. As a social worker, we spent a lot of time helping families to understand what the end of life was, what hospice meant. Some people thought if they went on hospice, it meant they died right away. Some people thought if they went on hospice, it meant that they gave up on life. These are the things that were happening in the 90s. I will tell you that now at 2018, the baby boomers that are coming with their parents, the baby boomers are a big, giant group of people. I'm right at the end, 1960, and they've looked at their parents and maybe their grandparents and said, we're going to do this differently. And they're coming and saying, we want to have a plan. We want to know what we want to do. We want to fill out advanced directives and most forms, and we want to be ready and prepared. And we're signing these forms at 50 and 60 and 70 years old. And I will tell you the average age at Columbine Health Systems is 88 years old. And what I've seen in my 36-year career is that when you are 88 years old and you're infirm and you may wear a diaper and you rely on us for care, many times, most of the time, you still want to be with us. Most of the time, you still want to be alive. You have found a different way to have your life going forward. We have people that choose to be chair of the resident council. We have people that say, I'm legally blind and I'm going to run the low vision program and honor that for you. What I have seen is that dying is an individual choice, and they're discussing what the definition of death is. I'm talking to you about your own social life as a person on this planet and when it's time. That most people want to be alive. Dementia patients want to be alive. I had a resident said to me once, why am I still here, honey? And I said, I don't know. I think there's more work that you're supposed to do. She goes, what is that work? And I said, I don't know, but I'll help you figure it out. She said, well, then I better figure that out. I'd better stay here. She was 98 years old. One evening, I was walking down the hall, and a resident of ours who was 102, and he wore a suit and tie every day and walked with a cane, and he said to me, can you come in and help me this evening? And I said, I will. And he said, can you help me take off my suit and tie and hang up my coat? He goes, I have a really hard time. My coat is heavy. It's hard for me to manage all of that. And while I was doing that, he said, it's been great knowing you. I have truly enjoyed knowing you. And I said, you're welcome. I've enjoyed knowing you too. And he said, well, if I die tonight, I wanted you to know that. And as a social worker in a nursing home, right away, you're like, should I get the nurse? I said, are you feeling sick? Are you ill? Do you have a fever? Is something going on? Should I get the nurse? And he goes, no, I feel totally fine. I'm doing well. I said, all right. Then the human developmentalist in me said, oh my gosh, he doesn't want to be here anymore. He is 102 and he lives in a nursing home. And I said, well, are you ready to go? And he said, I don't think I'm ready to go, but I am 102. The chances are getting greater every day. And I was 30, and it's quite a bit of wisdom to hear that from someone when you're 30 years old. And I thought about it as I was hanging up his coat and he was putting on his pajamas. I thought, I bet every night he finds someone to have this conversation in case he goes. But what must it feel like to wake up in the morning, one eye and then the other, and realize you're still in the nursing home and still here? I said, Raymond, if you wake up tomorrow and you're still here, what will happen? And immediately he said to me, I will put on my suit and tie and live another day. Thank you.
We've left just a few moments for questions. We have microphones to my left and to my right. We've got a talented and sensitive group of panelists, and I would urge you to take a few moments, if you're willing, to come on down and engage. Ask questions, share experiences. And I'll ask my friends perhaps finally to pick up those microphones, because we're going to need to respond to some of these questions. Of course, the questions can only come one at a time, and so if you're thinking about that, come on down. There are a number of issues at hand. Thank you.
I'll be the first. So thank you very much. This is informative. Not that it matters, but I'm a local physician. And so I take family doc, do a lot with the whole spectrum of life. But I'd like for you to weave, if you will, in, which is fabulous, the different cultures, the different belief systems, the philosophy, the impact on society that has occurred because of our capacity to not only allow people to live through a heart attack, through a stroke, through a cancer, but then to allow them to continue to live. And not the phenomenon of, well, this is bad, but how is this impacting society as a general term, certainly in America where the costs are, shall we say, exorbitant. And I look at the phenomenon of, here's what we can provide for you, but here's what we're not providing for other folks like our youth.
Thank you. Any of our panelists are welcome to.
Well, is this on? Yeah. I think in the last 25, 30 years, there has been a tension that has arisen between whether the response to patients and families who have reached a stage in their life different than Raymond, but are either not conscious or not able to engage in the activities of daily living in any way. Whether the way of talking about the issue that is presented there should be focused on what is valuable to the individual versus what it costs to provide the care that is part of their continued life. And there was a time when I think a lot of the emphasis was the concern that we are burning up resources. And I found in talking to physicians, particularly geriatricians who deal with patients, that very often when things are framed in that fashion, then a resistance arises to thinking about their own, what they value in life and are they continuing to have it. And I think that is even more pronounced when it is not the patient, him or herself, but a family member. So if a patient has been in the intensive care unit for a period of time and the physicians and nurses are firmly of the view that in their experience a patient with that set of issues is not going to leave the hospital alive, but could be there for a long time. Talking about how this is keeping us from doing other things with our resources produces a view that the person expressing that view is not taking the patient's interest to heart. Whereas talking about whether or not it is a condition that is actually valuable for the patient does get through to some of those patients and families. There were statistics that were given, for example, a number of years ago that 50% of Medicare funding was being spent on patients in the last 3 months of life. And Ann Satosky and I looked at those figures, and we saw that in terms of the major costs, in terms of high-cost procedures, there were two populations that were getting them, and they were almost as numerous, and that was patients who lived and patients who died. That is to say, it was very hard to make a differentiation as to whether or not those resources were going to produce a valuable result or not. And so just focusing on those high-cost procedures was not going to probably be, this is a different argument than the one I just gave, probably not going to be a practical way of reducing them. Now, people have looked at those numbers since then, and they're not as clear. It looks as though more of the high-cost procedures are going to people who are in those last 3 months. But it's very hard to know that they're there before it's retrospective that we know those were the last 3 months, not prospective. So I tend to be a skeptic about thinking that we will make a lot of progress in addressing what is a worrisome phenomenon. I'm totally with you in being worried that we are not willing to spend 50% of our GDP on health care, and yet with an aging society, we might get to that point. But I'm also willing to say if we had rational processes for deciding how we spend money, we could get to that point. I mean, health care is clearly something that people value. A lot of people who are interested in helping others work in health care. It's a good thing to have in society. If it turned out we spent a lot of money on that instead of on, I don't know, a lot of other things that might not be as valuable, we could decide that. The difficulty of it, of course, is that unlike deciding between sneakers and lipstick and widescreen televisions or something, that happens in a market, and we're sort of more willing to say that's an expression of consumer preferences, which isn't as true of medical care. So there are difficulties how we decide how much we're going to spend, but I don't think that focusing on the spending gets us as far as focusing on, is this of value in the end to the people? And so I would tend not to lead with that in trying to actually effectuate change.
Additional reflections from the panel?
Just, I guess, one quick follow-up comment. I take it your question has to do with sometimes this tension that you see, this intergenerational tension where people might judge that too many resources are going towards the elderly and not enough towards others. And oftentimes conflicts having to do with sort of distributive justice or the way goods are distributed are exacerbated by things like high costs. I think that we wouldn't worry quite as much if we could get our healthcare system in order. People are going to be much more at each other's throats intergenerationally when they're fighting over crumbs, and there's a sort of a sense that there's a sense of urgency. The pot is not big enough. And if we could get a handle on healthcare costs, those sorts of tensions between older people who naturally require more resources on average, healthcare-wise, than younger people, I think we could at least mitigate some of those tensions by doing something about healthcare costs in general.
If I could add, I entirely agree with Modi that but I see a connection with what I was saying, because if we're saying we're spending money generally in healthcare, not just at the end of life, that doesn't produce the quality of life and of care that we want, then we would focus on that, not that some people are undeserving of the care, but rather that we're not spending it effectively, and we're not looking at the rest of the things in society that are at least as important determinants of people's health and longevity as medical interventions, and address that and say, how do we have a better quality of life, live longer, live healthier in that life? And that can be a focus. And that's something, as people move through the aging process, those 80-year-olds used to be 5, 10, and 15-year-olds, and with luck, the 5, 10, and 15-year-olds will be 80-year-olds. So it's a matter of saying throughout that spectrum, how do we end up with a quality of life that is better without spending more and more? I was, I think, being somewhat hyperbolic when I said if we had a process that was rational that said, well, let's spend half of our GDP on healthcare. You know, why is that any worse than anything else? And it would mostly, I think, be a place we would never get to, because we would say there's so many other things in life that we value at least as much that we would have to give up. But that's not an intergenerational thing as such, because people move across that age spectrum. But the thing that you raise is so important. I mean, most of the European countries spend half per capita what we spend and have longer lives, healthier lives than we do. And it's not just because our health care is expensive and our systems are ineffectual. It's because of other things in those societies. Greater equality makes for greater health, for example.
3:30 has arrived. I just want to remind you that Professor Capron will be with us for a few more hours at any rate. He gives a lecture at 5 p.m. in Ballroom D on a related topic, or organ transplant tourism. And so I would encourage you, if your schedules permit, to join us upstairs at 5 o'clock. And as we close, I'd just ask you to join me in thanking our panelists for the discussion today. Thank you.